is my absolute honor to introduce our special guest today, Dr. Jared Baeten. Dr. Baeten is the Vice Dean of the School of Public Health and Professor of Global Health Medicine and Epidemiology at the University of Washington. He is an MD and has his PhD in epidemiology from the UW. So Dr. Baeten, welcome. I know we have a lot to talk about. We have a lot of questions for you, so I'm going to turn it over to Leah so we can get started. Thank you.
Yeah, again, Dr. Baeten, thank you so much for being here. So can you just start off, tell us a little bit about what you and your team, what you guys are doing at the University of Washington right now?
Yeah, hi everybody, and thanks for inviting me. This is one of my more unusual groups to be talking to. So, but thanks for invitation, and thanks for all that you're doing during this time. So, as was introduced, so I'm a physician and epidemiologist at the University of Washington, a place that you all pay for, and so I'm really happy to be here, and thanks for believing in us. Just really broadly, the UW has been right at the forefront of coronavirus stuff since months ago. It was actually UW researchers, both in the School of Medicine and the School of Public Health, who brought to the nation's attention that coronavirus had landed here, and it is because of work in the UW hospitals, the UW research labs in the School of Medicine, and UW School of Public Health, working with public health both locally and across the state, that we're doing everything we can to fight this virus. And as a state, doing pretty well. Could be doing so much better, but did in the last months much better than our compatriots across the country because of a lot of the work of the public and a lot of the work of people here at the UW. It's great to be here.
Awesome. So let's start out. Can you talk a little bit about where we started, back in March, February, and where we are now in terms of treatment and how we're managing the virus?
Yeah. Does anybody remember March?
No.
Barely, right? I know. So what we got is a brand new respiratory virus that spreads in ways very similar to how our winter and summer colds spread and our winter flu viruses spread, but is so much worse because none of us have had it before. So no one in the community has pre-existing immunity, and it does seem to spread efficiently enough that it goes like wildfire through populations. Where we started in March was just the first, the end of February was this first hint that there was transmission happening in the United States, first noticed here in Seattle, like I said a minute ago. And by the time that was noticed, the evidence seems to be that there were already hundreds, thousands of cases in this region and elsewhere in this country. We've gone since then through in this region and in the country through now what is hundreds of thousands of recognized infections, and unfortunately many deaths from this infection. And we've seen this wave sort of sweep across the country in different ways, starting in large cities first, and now what we're seeing is moving to some states that didn't get hit right at the beginning, probably because they had less contact with travel and other things like big cities like New York and West Coast cities had, and resurgences in smaller places like across the mountains here that weren't as badly affected in March, but now are quite badly affected.
Yeah, so as far as treatments go, right, what are we, because we're hearing all these numbers, right, the death rates are going down. So is that a good thing? What's contributing to that? Is it treatments? Is it, what is contributing to that decrease in death rate? And is it good news? How should we take this?
It's good news. So along the way, I'm going to do a lot of it's good, but things. And I want to say public health and doctors are not about scoldy bad, no funds. We are trying to hit the right balance of what's going on. So yeah, the death rate is going down in the US right now. That's a couple things, at least a couple things are reflecting that. one big part of that is getting better at treatment. We know as physicians and as other medical professionals a lot more about how we can treat people better with this disease now than we did in May, than we did in March. And that's a few things that are better in terms of the therapies that we use, and then how we even use some of our regular therapies, like how we use our ventilators and program them and use them and position people when they're on a ventilator, how we use oxygen and when we transition from just oxygen, like in a tube, to a ventilator. So that's part of it. So treatments are getting better. Are they great yet? No, we don't have great treatments for somebody who's in a clinic, doesn't have to be in the hospital yet, but might end up in the hospital in the next 4 days. We don't have a great treatment for that yet. We don't have the perfect treatment that can arrest somebody's infection when they get into the hospital. We have things that make it a little bit better. So better could get much better. The other thing is, right now, the people who appear to be getting infected much more are people who are less likely to be having complications from this infection. So early in this epidemic, some of the people who got hit the hardest were some of the people who had the most damage to be done to them, particularly people in nursing facilities, accounted for almost half of the deaths in the United States in the first few months. Right now, it appears to be a lot of younger people getting infected. They're less likely to have complications. It's good that they're not less likely to have complications. It means that there are fewer deaths. Now the but. The but is, just because young people are getting infected right now and they're less likely to have complications, doesn't mean that none of them are, because some of them are, and doesn't mean that we're out of the woods, because those individuals interact with everybody else in society in some way and can set up the resurgence. So we're doing really quite well here, particularly in the western part of Washington, but our fellow citizens in Arizona, Florida, and Texas are feeling what places like New York were feeling in March and April.
Yeah, I mean, and I guess feeding off of that, since we're having, a rise in cases elsewhere, should we be worried, geographically, because people travel, people do things, people go on vacation. Should we be concerned here in Washington?
Oh yeah, I mean that's what we should be concerned, but having concern keeps us attentive to be able to pay attention and look for the kind of outbreaks. So people traveling is clearly the big source of how this virus hops around from place to place. Like we have it in Washington State because people traveled from predominantly from Asia to the United States for here, and people have in New York because people traveled from Europe, where it landed, to get into New York to get there. So now, where we're kind of on a simmer, we're not really on a downswing. We were on a downswing, and now we're back up to a simmer here in Western Washington, at least. We could have new introductions if people take trips here from Southern California right now, which is having worse outbreak than we're having. But the great thing is that we've got really good, Washington State has invested really well in public health, and both at the local level and the state level, there are a lot of people who can jump onto outbreaks. So for example, recently here in Seattle, we had an outbreak right off the UW campus at the frat row that's just north of campus. And the huge amount of resources went into testing all kinds of people and then containing people to be able to prevent that outbreak from spreading more.
So when you talk about, right, we talked yesterday, and we talked about just kind of that domain of public health, right, and what public health experts do, right? We kind of talked about that's kind of what their purpose is, right? And that's how best you guys can serve our communities. Can you tell us a little bit more about that?
Yeah, public health is about keeping all of us safe. And so, if medicine is about keeping one person healthy. So when I'm wearing my doctor hat, I'm in a room with a patient or in a hospital room with a patient, trying to think about the very best thing for them. When I'm wearing my public health hat, I look out across my community. I think, how can we keep everybody healthy? And a lot of that is about prevention. And prevention is about taking actions now. Prevention, ounce of prevention, pound of cure. It's like taking preventions now so that we don't have worse things into the future.
Okay.
So that public health is this mix right now of trying to tell everybody about preventative strategies to keep everybody safe. That's what the masks and the physical distancing are all about, so that you're doing all the stuff that's going to make sure that this virus doesn't ricochet from one to another of us around a community. And then also containing when an outbreak happens. So that frat row outbreak, finding someone who's infected, figuring out that there are 2 people infected living in the same place, jumping on that, testing everybody they came in contact with and then everybody they came into contact with, and then putting a sort of virtual bubble around all of them so they don't spread it further.
Okay, that makes sense. The other number that we keep hearing a lot about recently is the hospitalization rate. Why is this such a big deal, and how should we be thinking about it as we go forward?
So what really matters with this virus is all about, it's all about the complications of this virus. So, there's it, and the complications manifest in predominantly, the worst ones are people who get hospitalized and then people who die, right? And when we think about the hospitalization rate for this virus, we should all be thinking about why that matters. And it matters because if beds in hospitals fill up with people with coronavirus, then those beds can't be used to take care of everybody else. And one of the most striking things, both here in Washington State and nationally, has been that when coronavirus was the worst, well, it's actually pretty bad now, but when it was, now a few months, we've got a few months more data. When it was bad back in March and April, people were certainly dying from coronavirus, but they're also dying of other things as well. And that's because hospitals, particularly in New York, for example, got so full that they couldn't take care of anybody else. And so that's what we're trying to do here in Washington when we're doing all of the little things that each one of us can do for prevention, is we're doing the little things so that Harborview or Swedish, or if you live north or east of the city, that those don't get filled up, so that if you get appendicitis, if you get hit by a car, that there's going to be a bed and a doctor waiting for you.
Gotcha. So yesterday you talked about the 2 factors of nature and duration when it comes to exposure and risk. Can you talk about and educate us a little bit more on that?
Yeah, there's so much. One of the things about a new virus like this has been, and I think the nature of our news feed is that it is just a barrage, right? These last few months of information. And new information all the time, and it's contradictory some of the time, and then you get a sort of a half piece of information, and then the other half comes a lot later. The basics of basics of a respiratory virus transmission like this is it's how close you are to somebody, so whether they can pass it to you, and that includes shaking hands and other stuff. How long you're in contact, because it's clearly different to sit down and have lunch with somebody than it is to walk past them as you're jogging on the trail or something like that. Because a second of contact is really different than an hour of contact. And then what seems to be really clear for this virus is it's also sort of something that you all would know a lot better, like the mechanics of the airflow around somebody inside. And so, sitting inside in a restaurant is probably different than sitting outside in a restaurant. It's certainly different than taking a walk down the street in your neighborhood.
Okay, so let's talk quick testing, because I know somebody's I had one later, but we're going to move it up a little bit. So let's talk about testing in King County. What's available, where are we at now, and where can we hope to get to as far as availability of testing and testing employees and people that are doing risky behavior and all those things.
Yeah. So the big things about testing, there's testing for the virus, things like the virus itself, that's like a PCR test is the biggest one, although there are new things called antigen tests that are coming out also. And then there's testing for prior exposure to the virus, and those are the antibody tests. Let's talk first about the PCR tests. The testing for the virus itself with the PCR test, so much in the news about, for months now, about stutter stepping, about how hard it's been to get testing done. One of the really great things is that Washington State invested early and hard in tests, and has done pretty well in its ability to roll out tests to lots of people. So if you go online now, there are many, many open opportunities for getting tests done where you can sign up online or get one ordered by your doctor. And that's a swab up the nose to see if you're infected, if one's infected now. And certainly anyone who has any new symptom should, first of all, stay away from other people and figure out how to get a test. So the 3 things I'm going to say over and over today are about masks, distance, and stay away from other people if you're sick. so you can get a test, UW Medicine. It's very easy to search on UW Medicine site for how to get a test in the UW Medicine space. That is testing for people who might be sick. The world is pushing more and more towards testing for people even a more screening kind of way in people who aren't sick. That includes people who've been in contact with other people. So like the frat row example I talked about, find 2 people are sick, test everybody around them to try to contain something. But also more and more, a few examples of, in particularly high-risk situations, trying to test people to make sure that they're not infected with no symptoms because they might expose people, like workers in long-term care facilities, for example. People coming into the hospital, everybody in the hospital system where I work now is tested when they get admitted, whether they're getting admitted for like a broken toe or potential coronavirus, and other things like that. And some airlines are some airlines or some countries, if you're going to travel out of the United States, are requiring people to have a test before they go.
Do you think we'll ever get to the point where, like every day you can give yourself a quick test?
I'd love that. Right now, I would do it. I would totally do it every day, and I'd love to like log it into my phone and right. Right now, the tests are not enough in quantity, but really not enough in price to be able to do that every day. You need to get something down to like cents, pennies, to be able to test every day. I think the thing that we know, the thing that's going to be clear, more and more clear from this coronavirus, like it is for everything that we do in prevention, is that each thing you do doesn't have to be perfect, but you layer those all together and that creates a really tight net to contain things. Same thing like when I get in my car. A seatbelt is not perfect, but I got a seatbelt and I got some anti-lock brakes and there's speed limits on me, and I put that all together and it keeps me safe almost all of the time.
All right, cool. So you mentioned antibody tests. There's so much mixed information floating around there in the media right now. What should we know about antibodies and antibody tests?
Yeah. So this is another one where we've got part of the information right now, and there's gonna be more later. So antibodies reflect that you've been infected. So if you had chickenpox, Leah, as a kid, you've got chickenpox antibodies. And they often stick around for a really long time. Antibodies to coronavirus, we can measure them in people. You can get an antibody test to see if you have been infected. What we know right now is that really only a minority of people, even in the worst hit places in this country and on the planet, have antibodies. So we're nowhere near getting a huge fraction of people infected that might get at something like herd immunity. And what we don't know is if having those antibodies protects you from getting infected again, and if it does, for how long. And that's something everybody's trying to figure out. In other respiratory viruses, antibodies can be protective, either about getting infected again or maybe from just getting worse symptoms from it. So you might get a slightly less bad symptoms if you've had it before than if you've had it again. Well, we don't know that right now, and we don't know how long they stick around. For other coronaviruses, like SARS, they stuck around maybe 6 months, a year, maybe a little bit longer in most people, but not forever.
Okay.
So a lot to figure out still, really frustrating.
So lots of stay tuned.
Lots of stay tuned. I think the takeaway from that is, if you get an antibody test, that's great. If you have positive antibodies, okay. Doesn't mean that you're protected. It doesn't mean you have to do any less for everybody else around you.
Gotcha. It's not a free pass.
Not a free pass.
Gotcha. Okay, so what is herd immunity, and can we reasonably get there, and should we even want to try to get there?
So herd immunity happens when enough people are infected or vaccinated with something that it becomes really hard for a virus to bounce from person to person to person, because every time it's trying to bounce from person to person to person, it's hitting enough people who are protected that it can't go any further. So for measles, for example, we get to herd immunity. You actually need measles. You need people up in the sort of 90% protection to get herd immunity to measles. When you dip down a little bit below that, suddenly you get little outbreaks in places. For coronavirus, the hope is that if you could get to 60, 70 maybe %, that it would be hard to transmit from person to person. The challenge is we're really far from that right now. So so it's a big study from Spain, which had a really bad outbreak of coronavirus in April. Just came out the other day, and they estimated about 5% of people in Spain had coronavirus. So to get from 5% to 60% would mean doing that all 12 more times. No one has the appetite for that level of pressure on the health system and that many people dying 12 more times. So it's going to take a long time to get up to there. If we can get a vaccine into the mix, it'll get us to herd immunity a little bit faster and easier.
All right, so great segue. So can you tell us where we're at in terms of a viable vaccine, and what can we expect over the coming months?
Yeah, there are dozens and dozens of vaccines being tested right now, which is amazing, because research and development in health is always accelerating, but this is the fastest that anybody's ever expected something to go. So there are a bunch of vaccines that are in testing. They're going to have information. They're going to have information this next year, and hopefully even by the end of this year, which is really encouraging. We'll see. The first ones that are being tested, people have got a lot of enthusiasm for them. The caveat is everything would have to go perfectly for them to be all up and ready by December, January of this year. And a lot of things don't go perfectly in health research, because, especially when there's something new, because you're searching for something new. A first vaccine, or first or second or third vaccine, might protect not at all. That'll be a bummer, but then people will learn from it. And the good thing is the vaccines that are being tested are really different from each other. So there's a lot of opportunity for, if this pathway doesn't work, maybe this one would. The second thing people have to be ready for is, particularly for this kind of virus, because of how respiratory viruses are transmitted, that it may be that the first vaccine that comes out isn't a home run vaccine, but provides some protection. That's still good. That's like our flu vaccines every year. Our flu vaccines every year don't make you invincible from flu, but take it down, and at the community level, take it down a lot. If we can get that for this coronavirus, if we can get it out of the bat for this coronavirus, I would be thrilled.
Awesome. Okay. So let's talk about the 6-foot rule. Where did it come from, and why 6 feet?
Yeah, I think I said to you yesterday that I'm originally from Wisconsin. I'm a Seattle person, really, in my heart, and so I like 7 feet even better, if not a little bit more. So 6 feet is a good guess of how far your breath goes, or your cough goes, or your sneeze goes if you're around other people. There's in this kind of health communication, there's nothing magical about 6 feet. That you're at 5 feet 11 inches, somehow everything is worse, and if you're 6 foot 1 inch, you're totally protected. But it's giving people sort of a marker to think about, I should stand, I should be this way. In the same way that we give the same way that everybody's got their 8,000 or 10,000 steps in there programmed on their watches, that if you do 7,999, it's not like you're without health, and it's not like you're perfectly safe if you do 8,001. So 6 feet keeps you far enough away from people that casual coughing or breathing is going to protect you. But even more, if you're wearing something over your face and somebody next to you is doing the same, and you're kind of and the normalization of wearing those masks is that everybody's wearing them.
Okay, great. So what is the best thing our employers can be doing for their workers right now in regard to COVID?
Yeah, it's a great question. So I think it's taking it seriously, and as bosses telegraphing it seriously, that this is important. We care about you, and we care about doing this right. Prevention is tough because you got to do it every day and all the time, and you have to sustain it. It's the same. It's just like going to the gym or flossing your teeth. It's getting into the habit of doing it, but then doing it over and over again. So making it clear that it's a priority, making sure that people are wearing masks and standing apart from each other as much as you can, and particularly staying apart from each other when they're indoors and the weather and the airflow is less. So I care a lot about transmission in in indoor spaces, because that seems to be really, really important. Doesn't mean that that there's zero risk when people are outside, but when I think about your office workers or your folks working on installing something in a building when they're in a small space, taking their lunch break sitting in that space is way worse than if they could be sitting outside or sitting in different rooms for something.
Okay, great. So right now the big hubbub is all about school. So there's a question in the chat box, reopening schools in the fall. Do you have any thoughts on whether that can actually be done safely?
I have many thoughts. I also have a 10-year-old, so I'm going to try to separate my personal about school from my from public health things about school. So and this is one where the discussion of schools is really, really important, because public health is not all about this disease, right? Public health is about the health of people, and that's their mental health, their physical health. It's about education and violence and everything else that can be happening. So the debate on schools is, how can kids be in school where clearly they would be doing better intellectually, socially, emotionally, nutrition-wise, everything else? And how can you construct processes for that so that they can stay safe and that the people who interact with them all day long can be safe? If there are any silver linings in this epidemic, it has been that kids in general do not get as sick with this virus as people who are older, and that's fantastic. I think we would be in such a different world of hurt if kids did worse with this infection. And so that if there are outbreaks in schools, that kids themselves, on average, will probably do just fine. The debates are how to set up schools to be as safe as they can be, and I think the people who are in charge of schools are putting their darndest into it to figure out how to distance kids in schools and put things in place so that kids can be there as much as they can. And the people who are a lot more expert at this, including physician colleagues like the American Academy of Pediatrics, really have put out a lot of statements to really try to remember that it's a balance of trying to do all the best for kids and the best for society and teachers and whatnot. So hopefully people are weighing that all together.
Yeah, cool. All right, so one more question from the chat, and then we'll kind of wrap things up with your final thoughts. Why aren't the media and the politicians, this may not want to touch this, discussing things we can do to increase our immunity, and why is there such little focus on those that are at high risk?
Yeah, so at least there's at least 3 questions there, so
right.
I'll try to
unpack it.
So, the focus on people at high risk, really important. So there are clearly individuals who suffer more, who are more likely to suffer from this virus than others. And the whole point of, if you're in that category, doing the most you can to protect yourself, or if you've got people really close to you, particularly physically close to you, to do the most you can to protect yourself. If you're not in that category, part of the reason you're doing all the other things you should be doing, like putting on your mask and staying away from other people as much as you can, is to help those people out, because they're either close to you, or they're either close to you somehow, or they're part of our community. The great thing is that simultaneous to all the other things we've been doing in public health and prevention, we've been doing a lot of stuff to make sure that we can put as many bubbles around vulnerable communities as we can. And so one of them, for example, is nursing facilities, like we talked about at the beginning, to be able to, a lot of them have many better processes in place now than they did when they were surprised by this virus in March, to be able to screen workers and then screen and pounce on infections if something happens in those places. Boosting immunity. The challenge with boosting immunity. So in a lot of my life, I work on HIV, both treatment and a lot on prevention. And the challenge is boosting immunity is, there aren't easy fixes for how we boost our immunity. I think as a society, the more we can do to eat right, sleep right, exercise, we can all do better if we happen to become infected with this virus. And then I'm happy to talk about politics and messaging, but I think that the basic messaging that I always go for in public health is, I do all the choices I make because I really care about the people close into me, but I care about the community I live in too. And so I'm doing my darndest to wear a mask and physically distance.
So basically your last final thoughts, wear a mask, physical distance, and any other last thoughts and recommendations.
Mask, distance, isolate and cooperate if you get a call about an exposure. And we truly are all in this together. And I've been incredibly impressed with the particular things that I can see close into me, my community here, about how people have bought into some really complex and super life disruptive things, like keeping our kids at home and wearing a mask to go to the grocery store and everything else. And it makes me feel really good about living in Washington.
Yeah, awesome. All right, that is all the time I have for questions, unfortunately. So with that, I'm going to pass it back to Robin to wrap us up.
Thank you so much, Dr. Baeten. It has been so special to have you here today. Having direct access to you has just been amazing. So we really appreciate your time. And we hear your message loud and clear about the masks and social distance and isolation and cooperation. So thank you for that.
It was a pleasure. Thank you very much.
Oh, we really wish you the best and love to see you again at some point. So hopefully with a better update as far as, maybe we'll be well beyond where we're at now. So
that's my hope too.
Thank you so much. And a reminder to all of our members, we have Toastmasters coming up on July 22nd at 2 p.m. and we have an economic forecast on July 29th, also from 2 to 3 p.m. And we have speakers coming from Western Washington University. They're the co-directors of the Center for Economic and Business Research. So that will be a real treat. It will focus on a regional forecast and also talk about construction. So I wish you all well. Thank you again for tuning in today, and we will see you soon. Take care, everybody.